Hey everyone, today I'm diving into the essentials of managing an upper gastrointestinal bleed, specifically for all you interns and residents out there. This is one of those critical scenarios every medical professional needs to be prepared for. So, let's get into it. First off, recognize the signs. Upper GI bleeds often present with hematemesis, which is vomiting blood, or melena, which is black, tarry stools. Less commonly you might see hematochezia, bright red blood per rectum, if the bleed is really brisk. Remember, any sign of instability like hypotension, tachycardia, or altered mental status should set off alarm bells. Prioritize your ABCs: airway, breathing, and circulation. Next, let's talk about initial management. Start with 2 large-bore IV lines. You're going to need them for fluid resuscitation and blood transfusions. Crystalloids are your first step, but don't hesitate to move to blood products if the patient is hemodynamically unstable. Aim for a hemoglobin level around 7. 8 GDL, but higher if the patient has cardiovascular disease. Don't forget to order labs, CBC, coagulation profile, liver function tests, and type and cross-match. Get a nasogastric tube in to assess ongoing bleeding and to help clear the stomach for endoscopy. It's not always pleasant, but it's crucial. Proton pump inhibitors like IV pantoprazole are a cornerstone of initial management. They help stabilize clots and reduce the risk of rebleeding. Start with an 80 mg bolus, followed by an 8 mg/hour infusion. If you suspect variceal bleeding, consider adding octreotide to reduce splanchnic blood flow and portal pressure. Once your patient is stabilized, get gastroenterology on board for an urgent endoscopy. Timing is critical. Endoscopy within 24 hours is ideal, but sooner if the patient is unstable. This procedure is both diagnostic and therapeutic. A quick note on risk stratification: use tools like the Rockall score or the Glasgow-Blatchford score to assess the severity and prognosis. These tools help guide your management and determine who needs intensive care versus those who can be managed on a medical ward. Finally, let's not forget about secondary prevention. If the bleed was due to a peptic ulcer, test for H. pylori and start eradication therapy if positive. For variceal bleeds, beta blockers and repeat endoscopies for banding are key. Educate your patient on avoiding NSAIDs and other ulcerogenic medications, and that's a wrap. Upper GI bleeds can be daunting, but with these essential tips you'll be well prepared to handle them. Keep learning, stay curious, and most importantly, trust your training. Thanks for watching. If you found this helpful, don't forget to like, comment, and subscribe for more medical tips and insights. See you next time.